Hello and welcome back to the channel. Today we're diving deep into a serious heart condition, infective endocarditis. So what is infective endocarditis? At its core, it's a microbial infection of the heart's inner lining, a heart valve, or an intracardiac device. This infection leads to the formation of what we call vegetations. Think of these as clumps made of microbes, platelets, and fibrin. The most common culprits are bacteria, particularly Staphylococcus, Streptococci, Enterococci. Fungi can also cause IE, especially in people with weakened immune systems or those who use IV drugs. The signs and symptoms. The presentation of infective endocarditis can be tricky because it can range from a subtle, slow-burning illness to a sudden and severe crisis. The signs and symptoms are a direct result of the infection, the damage to the heart, and the body's reaction to it. First, the general signs of infection. The most common symptom is an unexplained fever, which can be accompanied by chills, night sweats, fatigue, and muscle or joint pain, myalgia and arthralgia. Patients often just feel generally unwell. Next, the cardiac signs. The most important sign a doctor will listen for is a heart murmur. This could be a brand new murmur or a change in a pre-existing one. Then we have the classic peripheral signs. These are caused by either tiny septic emboli, small pieces of the vegetation breaking off, or by the body's immune response. Regarding the signs, you may see the followings. Petechiae, tiny purplish-red spots on the skin in the whites of the eyes or on the mucous membranes. Splinter hemorrhages, small dark lines under the fingernails. Osler's nodes, tender, painful, reddish nodules on the pads of the fingers or toes. Janeway lesions, non-tender, reddish, pink, flat spots on the palms of the hands and soles of the feet. And Roth spots. These are hemorrhages in the retina that can only be seen during an eye exam. Finally, signs of severe complications. As the disease progresses, patients can develop symptoms of heart failure, like shortness of breath and swelling in the legs, or signs of a stroke if an embolus travels to the brain. As you can see from the symptoms, the effects of infective endocarditis are far-reaching and can be broken down into two main categories. First, the cardiac manifestations. The vegetations themselves can cause severe damage. They can destroy heart valves, leading to significant leakage or regurgitation. Second, the extracardiac manifestations. The problems don't stop at the heart, may lead to embolic events or immunological response. The modern way to classify infective endocarditis is native valve endocarditis and prosthetic valve endocarditis. Native valve endocarditis (NVE), an infection on a person's original heart valve. Prosthetic valve endocarditis (PVE), this occurs on an artificial heart valve. The new guidelines stress that surgery is often needed for prosthetic valve endocarditis, especially if it occurs within the first 6 months after implantation. How we reach diagnose, we depend on what's called Duke's criteria. Positive blood cultures, still key for identifying the causative organism. Positive imaging for IE, it's no longer just about the echocardiogram. The new guidelines have elevated findings on cardiac CT scans and 18F-FDG PET CT scans to a major criterion. This is incredibly important for tricky cases, like infections on prosthetic valves. Surgical evidence. What a surgeon sees during an operation can now be used as a major criterion. Minor criteria. Having prosthetic heart valve, previous history of endocarditis, IV drug Wessers, fever, vascular phenomena like Janeway-Keesian, immunological phenomena, signs of immune system reaction like Osler's node, Ross spot, glomerulonephritis. How we make the diagnosis. A definitive diagnosis is typically made by having either 2 major criteria, or 1 major and 3 minor criteria, or 5 minor criteria. Treatment for IE has become more aggressive and collaborative. It needs endocarditis team. This team includes cardiologists, heart surgeons, infectious disease specialists, and imaging experts all working together. Antibiotics. Empiric therapy, starting antibiotics before the exact bug is known, should target the most likely offenders. Recommended antibiotic regimen are ampicillin plus flucloxacillin. For early prosthetic valve endocarditis 1 year post-operation, use vancomycin plus gentamicin plus cefepime. For late prosthetic valve endocarditis, means after 1 year of valve replacement, use vancomycin plus gentamicin plus ampicillin. And then according to culture results, we give antibiotics. Surgery, earlier and more often. This is perhaps the biggest shift. The guidelines now advocate for earlier and more liberal use of surgery. The three main reasons for surgery are: heart failure. If the damaged valve is causing heart failure, surgery is a must. Uncontrolled infection. Prevention of embolism. Did this video help clear things up for you? Let me know by hitting that like button. And if you want to keep learning with me, make sure you subscribe and click that bell.